Welcome everyone to another Unfiltered Production. Nobody puts Gigi in the corner. That's a reference to a movie that Cindy and I watched. Cindy probably watched it later than I did, but it was like one of those formative movies that I grew up with. And if you're not familiar with that quote, it's nobody puts baby in a corner, and it's from Dirty Dancing. And it basically says that nobody puts someone in the corner and makes them feel inferior when they're indeed not. And Gigi's were never inferior. They never should have been inferior. So please don't put them in the corner. But this might seem a little familiar to some of y'all that we did this earlier, kind of Groundhog Day-ish. We noticed, or we had someone reach out to us and notice some possibly inconsistencies, maybe not enough information to explain thoroughly. Maybe we were wrong in the previous podcast. And so we wanted to take the opportunity to record this podcast and get it accurate, because we feel like at K&K, the most accurate information that we can get out to the industry, the better. And so sometimes that you have to admit that, hey, things got awry a little bit. And so that's kind of what we're doing today. But I told Cindy I was going to bust her chops a little bit this morning because she's wearing black today, y'all. She's in mourning. Because it's like cicadas. Every 10 years, Cindy Kraft makes a mistake. Every 10 years, the cicadas show up. And Cindy's had a rough night dealing with this small error that she made. But those of you that know Cindy Kraft know that it's super important to her. And it's in her gut to give accurate information. And so thank you to the listener who contacted us and asked the question. And it made us go back and look at the information. And I'll let Cindy explain it. Cindy, do you want to explain? First of all, I want to make it very clear to everyone that the GGs are out of the corner and are replacing the functional items as the calculator for VBP. That's clear, right, Cindy?
That's what we clearly see in the proposed rule. For the handful of you who watched the previous version of this, the bones were accurate because GG is going to move front and center into that calculation. That's their intent as they continue to modify value-based purchasing. But I can tell you exactly what happened, Sherry. When I'm looking at the information and they're talking about how to use the GGs in this, they talked about looking at our ability to what we achieve at discharge. And I got super excited that finally the goals column was going to be it. And I jumped the gun in my head to, well, okay, you're going to ask us based on what we projected, how often do you actually attain that? Well, that's not actually the case. Going back with a fine-tooth comb, the reality is that I think due to concerns about gaming, and we're just going to own it here at Unfiltered Productions, a portion of the industry has done that for the last 20 plus years in terms of the assessment of function and its relationship to reimbursement and compare scores and star ratings, that they not only want to change some of this with value-based purchasing, but they want to change it in a way that gaming is nearly impossible, that it really is going to be out of our hands. So it's unfortunate in my mind. I got super excited that, okay, what I put in the goal column is really going to be looked at. And no, what we learned from our very astute viewer was there's a statement buried in the proposed rule where they intend to remove the goals column from GG 0130 and 0170 completely in the next OASIS update because they aren't going to use them for anything, which again speaks volumes of what is our data showing in there that they have found it not to be useful. And I think in our reviews, Sherry, we see a lot of, kind of this GG in the corner, all the goals being all sixes, all the goals being the same on every patient, questioning if that's really an accurate representation or a clear understanding, or we still encounter more than the occasional agency that hasn't put a lot of effort into GGs. It doesn't affect reimbursement. It isn't part of compare scores. It didn't land in PDGM. So it's been seen kind of as less than by more than the occasional. Now, there are many that have been on top of this, and I think that's going to put them in a great position going forward. But we want to issue a wake-up call to folks that have said, well, does it really matter? Oh my gosh, it's going to matter big time as we go forward.
And it's just, the statement is just the GGs is just absolutely not correct. But Cindy, is it all the GGs though?
Well, that's what's interesting, because what we want to bottom line summarize first is they're proposing with calendar year 2025, that the measure related to function, they acknowledge that the measurement of function is a key element within value-based purchasing. But their plan in the proposed rule is to jettison completely the M1800s. Get them all out of there. The bathing, the upper body dressing, all those M1800s out of the calculation. We know they're in there today in that composite score, so they'd all be stripped out and replaced with GG. Again, that sounds like, yay, there's a whole bunch of GG things. Now we get to talk about all kinds of, nope, we do not. It is a subset of GG. And Sherry, I'm going to just kind of read through this quickly. You and I have already discussed, as this moves potentially from proposed to final, K&K fully intends more robust resources around this, but this is a podcast, a call to action, a way to shake the cage. So we're not going to go super deep dive, but what we're saying is going to be the actual measure is eating, oral hygiene, toileting hygiene, rolling left to right, lying to sitting on side, sit to stand, chair or bed to chair transfer, toilet transfer, walking 10 feet, walking 50 feet with 2 turns, or wheeling 50 feet with 2 turns, depending on their mobility level. Do you notice any big things particularly related to self-care that might be missing in that list, Sherry?
Absolutely. And not only that, in the house, you have to walk more than 10 feet.
Well, I mean, you look at it and say, first of all, how are we losing bathing, upper body dressing, and lower body dressing? And if it's home care, what happened to the car transfer? What happened to the stairs? What happened to the picking something off the floor? Well, there's a reason that's not on the list. And that goes back to the Impact Act and the initial discussions about cross-setting measures. Sherry, you might remember, I still have a bit of an eye twitch when anybody might mention the CARE tool. That was an original idea that was going to make all 4 post-acute settings use the exact same assessment tool. Thankfully, that died off. That was never going to work given the variation. But they wanted to take certain items and make them consistent across SNFs, IRFs, long-term acute care hospitals, and us. And much like a train, they organized who was going to get them implemented when, and we were the caboose. So we have to keep in mind other settings have gotten GG information. They've been collecting it, getting feedback on it, getting reports about it as far back as 2016. We didn't get to the reporting phase until 2019. And then, oh, what happened in 2020? Some stuff happened that kind of delayed our ability to get that information back. So when they're moving ahead with this for us, they're using the items that are currently active across all 4 settings. And if you look at long-term acute care hospitals, their GG data set does not contain the bathing question, upper body, lower body, footwear, stairs. Those things are not there. And you kind of go, well, given the patient population in a long-term acute care hospital, I kind of understand why some of those wouldn't necessarily be seen as useful measures, but it is present for SNF, IRF, and us, but they're honing in on only the ones that go across all 4. So that decision to not implement all of the GGs in one of the settings has ramifications for everybody else.
And I
So
want to
that's
make sure that everybody understands the 4 settings are long-term acute care hospitals, inpatient rehab facilities, skilled nursing facilities, and home health.
Mhm.
And this goes back to the Impact Act of 2014. That is law. It is not a rule. It is not a statute. It is law. And so the onus has been on CMS to implement this law. And we're going on what? Let's do the math. 9 years
Yeah.
to get to this point. And CMS has kind of acknowledged that 2020 to 2022 are sort of a data minefield in that it might not look the same as it did in 2019 as it has in 2023 due to the public pandemic and the changes in practices. So they're kind of looking at that data and saying, we're going to use it as reference, but we're not necessarily going to use it as our rule data, correct? I mean,
Yes.
That's kind of where we're at right now.
Right. So it seems like our caboose status of coming late to implementation got even more disrupted by this somewhat hiatus in terms of that type of data. So it's almost like we jumped ahead in a time warp to going from, yes, we collect it. And we very recently got some questions, Sherry, where people are still wondering, do we have to put goals in there? Which ones do they actually use? They've been sitting on the data this entire time and are jumping from basically collecting it to a financially impactful move. So baby's not just coming out of the corner. She's going on the stage with the lights and the music and jumping off into somebody's arms, right into value-based purchasing. And you look at it and say, okay, so I kind of like it. I mean, it gives us, a different way of looking at function. It might help some more people take the GG seriously. But then there's a catch to this, Sherry, because the measure still says it's looking at discharge. How successful were we in achieving functional levels for those questions? Which brings up two issues. One, well, if we're not projecting it through a goal, where are they getting it from? Well, I am not going down the deep dive hole of statistics and p-values, and we'll find somebody, maybe Sherry, and do another conversation that can explain that part.
I'm interested in that complicated math. Let me know, and we will get an expert on.
Oh, we can. But for today's conversation, what they want to do is take our initial assessment of these, so whether it's start or resumption of care, and run it through a rather complicated risk adjustment model to project the discharge values.
Based on the answers to the other items, right?
Right. So the core of it is, where are we starting? So what are we saying is the patient's level of ability at this point in time for this particular subset? So I want to kind of give folks an idea of what are those variables that are going to be in that risk adjustment. So they're going to be looking at the patient's age. They're going to determine based on, wait for it, Sherry, diagnosis coding if they had prior surgery. What was their prior function and prior device use? So two other GG items with respect to what was going on before. Information related to pressure ulcers, cognitive functioning, incontinence, availability of assistance and living arrangement. So we're talking about item 1100, about who's available and when. Admission source, BMI. So when we were auditing those records, Sherry, and people skip height and weight, we got an issue because BMI is coming into this. 1033, the risks for hospitalization, confusion in the last 14 days, vision, medication management needs, so both oral and injectable. And then item 2102 with respect to supervision and safety. And wait for it, comorbidities. So diagnosis coding is going to end up in two ways. Big one being the comorbidity issue. The other being whether or not they've had surgery. So for surgery, they're looking at a specific set of Z codes. For the comorbidities, they've already made these groupings that are available in a document that Sherry, we're going to send it with and attach it to this podcast, because it gives great detail about how they're going to do this for home health agencies. And guess when they release that, Sherry?
When?
June 2023. So right around the time of the final rule, proposed rule, here it is. So those who want to go into the math, because they show you all the statistical stuff, you can get super excited. But that is a lot of stuff into risk adjustment. So again, I think the complexity that's good. I mean, it's good they're considering cognition and pressure ulcers and access to caregiver. I mean, I think that's a really good mix, but it also makes it very inefficient to game. It goes back to what K&K has been saying for a decade, and I've been saying for more than half my lifespan. This comes down, as always does, every question, every time point, every time has got to be the best, most accurate, guidance-driven answer possible. That's my responsibility as a data collector. And when we see folks still talking about money items, I hate that term, or only do these, we're at risk.
I want to interrupt you because I'm the dichotomy of this is there are still money items, and there's a split between the money items and the value-based purchasing items, which are in essence money items when you're talking about a 2% to a 5% reduction or something like that. And forgive me, guys, that's not 100% accurate. Reduction in payment over a span when value-based purchasing kicks in 2025. As a reminder, we're in a data collection year right now, and I want to make it really clear, we found out that this was the data they were looking at for value-based purchasing at the end of June. So we have collected this data now for 6+ months and not had that focus on the GGs that we need. And what you have to be very careful of is because a lot of folks want to make the functional items look worse. And they do that in order to drive up their case mix weight, which drives up their payment score along with their coding and all these other things. And then you look at the GGs and it's almost like looking at a different person. So you have to make sure that there's some congruency between your GG items and your functional items. They may not ask the same questions, but it's really hard to defend that someone is dependent in bathing, yet they can stand up and dress themselves and do all those other things in the GG items. That's a very difficult defend. Is that a fair thing to say?
Yeah, I mean, I would argue that the data that they've been looking at has been since 2019. Yeah. I mean, it doesn't really even matter anymore when they say we're going to do this with this year and this point, because historically, when we've reacted to that, look what happened with PDGM and the functional scores. They originally built PDGM to be a third high, a third medium, a third low. We go to PDGM, everything shifted to more acuity. Then we fixed it. Oh, then it shifted again. And now they're talking about for 2024 having to recalibrate it again. Anytime we react and start doing stuff noticeably different because of a payment implication, this throws gasoline on the perception that we're gaming the system. So this is a bigger data collection issue, but I want to reinforce what you just said, Sherry. First, the 1800s are not being removed from OASIS. They're not. They can't be, because they're still in PDGM, they're still in Compare, they're still in STARS. So they're not going anywhere. The issue is in value-based purchasing, what's being pulled to calculate is coming from GG and no longer has any relationship to the 1800s. But those two sections have to have a degree of harmony. As Sherry said, if we're saying you look terrible over in this version and you look better than that over here, there's a concern. And the issue means that we have to look at it and say, it's never going to match completely because there's two different scoring guides, but it needs to make sense. And sometimes I agree, it does not, because the definition of dependent for GG items is, what we understand dependent to be clinically, but it also says if the person needs two people to assist, even if it's one person picking them up and the other person is just giving verbal cues, that's two people, that's technically dependent. So you could end up with dependent in a GG and not in an M, but you have to look at the bigger picture as a whole. But in our bit of time we have left, Sherry, I want to hit on one more piece. And that is, if we're going to be having all of this basically done by math, there's two issues. One, I absolutely have to make sure that my initial assessment is correct in the GGs, all of them. Prior device, we just said prior device and prior level of function are part of risk adjustment. And I don't want folks to say, good, here's the short list. This is what's going to be in the measure. This is what I'm going to focus on. Because there's one other issue. And that is the fact that in GG, we have the ability to use activity not attempted codes. And you'll see that in data from CMS, they'll shorten it to ANA, activity not attempted. And we have 4 of them right now. We have the environmental issue, we have a patient refusal, we have 09 that says the patient could not do it before and they can't do it now, so it's not applicable. Or we have 8 with medical contraindications indicating, bottom line, the patient cannot do it now, but they could do it before this illness, exacerbation, or injury. We also do have the ability to dash some of these. So there's this group of responses that don't really give us a baseline in the technical sense. So it's not a 1 of dependent ranging all the way up to 6 that's independent. So having been part of one of the TEPs associated with this, the technical expert panels, the decision was made, and not everyone agreed with it, that to convert anytime we use one of those activity not attempted codes, by looking at the patient's performance in the entire body of the GGs, to use magic math to convert those to a response level between O1 and O6. Now, you can imagine there was quite a bit of discussion related to this in terms of one model said all of those should just be converted to 0-1 for dependent. And that's like, wait a minute, if the person couldn't do it before and can't do it now, that's not dependent. The patient refusing doesn't mean they're dependent. So they abandoned that one. Thank you. But this mathematical inference is a bit complicated and more math than my head can contain. My clinician brain goes, wait a minute. So if you wanted somebody to infer their ability, why can't it be me? I'm the one with the patient. But that raises the question. I think we need to be very cautious. And I want to be very clear here, Sherry. K&K is not saying don't use ANA codes. That's no, we never speak in absolutes. But think about it before that's the one you're going to land on. Because it does say in the guidance that you can interview patients, you can talk to their caregivers, you can talk to other disciplines seeing this patient in the appropriate time window. There's multiple ways to look at this. And if I can get an answer, a real answer between O1 and O6 based on following the guidance, I want to do that. It's in my best interest. If they're going to use that as the foundation of the math of predicting something, I'd rather have a say in it than put down an ANA code and then they use other response items to mathematically because the statistics say it's valid, all that other stuff. I personally don't think it's as valid as the person who's assessing the patient and the team who actually works with them. So we're not saying don't, because there's going to be situations where an O9 is absolutely, they could not do this before and they cannot do it now. But some of those others about patient refused and that, maybe we need to think about, let's go back to the guidance. What are all the things I can consider? Maybe they didn't want to do it right now, but I have enough information based on these sources to pick a response level for them. I need to consider doing that because I would rather see us make that decision than math. But please don't take that away with Cindy Kraft just said fake numbers because of, no, that's not it. But it also speaks to if they're going to use GG items outside of that subset to make that inference, the whole thing has to be accurate.
100%. And Cindy, you know, I watch Olympic sports and I really like gymnastics and I tolerate figure skating, but this scoring is a resemblance of that. You know, you sit in the kiss and cry and you wait for your scores and you see this random group of numbers and then they end up always throwing off the Russian judge and somebody else on the other end. And no offense to Russians, just that they're typically a more difficult.
Well, it depends who the contestant is, because then it seems to be other trends get chucked too.
It's not making that inference, but I agree with you. But that complication where you kind of go, why can't they just see who did it the fastest, like they do in track and field? This math is something that you really don't need to worry about if you portray an accurate picture of your patient. That's the key here, is to look at your patient, to assess your patient, to reflect in the documentation exactly what that patient looks like according to the OASIS manual guidance, and get that, and that gives you the reimbursement that you need to care for that patient. And you know, sometimes they don't, sometimes you have winners, sometimes you have losers, but to concentrate on that math is what CMS almost is baiting you to do at this point, because they understand the history of our industry and some of the things that happen. And those of you that are using these data mining companies to determine what level of care you're going to provide and what patients you're going to take on and things like that, CMS is kind of just doing the same thing, just from the other perspective as a payer. So the data, there's like a data war going on in our industry that really, honestly, as a clinician who's seeing a patient in front of them and having to take care of them and keep them in their home and keep them out of the hospital, the most important thing is that you're accurately describing that individual and each individual that you see, and trying not to become homogenous so that you're detected on the other end. And Cindy, I just want to thank you from the bottom of my heart for coming here and apologizing and you know, throwing yourself at the feet and wearing black and tearing your shirt. I think she's covered. I see windows that are uncovered, so we're not in that deep state of mourning, but I want everyone to understand that we do have solutions to this issue. For those of you that might be scared to death of what your GGs look like right now compared to your 1800s and vice versa, we do Oasis audits, and a lot of folks do Oasis audits. We do Oasis audits where we pick a sample of your charts from this year and give you the information. And we also have a product that we just released, and Cindy went back and reviewed, that talks about how clinicians should collect the data on the functional items and the GG items, ironically. And that will be in the same newsletter as this. So Cindy, what is your takeaway positive from all this? I know that you and I spoke about a positive earlier. So
I think a big positive is that these kinds of things can get us worked up. And you can see I got a little, I'm so fired up now today. I'm going to have to go take a nap or something. But the issue is, I believe the majority of clinicians are doing the best possible care and the best possible assessments for their patients. They just get hung up because they don't necessarily like the Oasis wording. They don't really understand some of those nuances. And so I think the positive is we need to drive this back to discipline neutral data collection, and let's look at the guidance. I don't have to like the guidance. I need to stop fighting about the guidance and being upset about the guidance, and really reinforce your clinicians that are doing well. I think sometimes we get hung up, and it's a side effect of being in the consulting space, of wondering, oh my gosh, does anyone really understand this correctly? I believe there are a lot of clinicians that do. And so, as speaking to leaders briefly, it can be very quick to hone on, oh my gosh, I think our GGs are messed up and they don't know what they're doing. And but we also do Oasis testing, an Oasis knowledge assessment program here to help weed out who really needs the follow-up versus bringing everybody in and telling them the sky is falling, our GGs are a mess, and it's all you. Very often, the majority of the clinicians there are doing it right. And they're the ones that get upset that they must be doing it wrong if I have to go to this education. So really reinforcing your strong performing clinicians to say, yep, you get your assessments right consistently. Maybe look at some mentoring of co-visits with clinicians that are struggling with that, with someone who understands it a bit better, looking at reinforcing that good behavior and taking away this Oasis is awful, training is a punishment, and we always stink at this. But really looking for your strong performers and capitalizing on them.
And the solutions that we have are so reasonably priced per agency, but go out and find some education, even if it's not with K&K, that's going to reinforce the positives that is going on in your agency, and then remediate the ones that need to be remediated. And with our staffing difficulties, the days of having cattle calls and going off clinical for a day for half your staff and the other half of your staff is just not reasonable. People are being strung a little bit thin with all the staffing issues. So I want to take a moment and thank everyone for listening to our Unfiltered Production. We have these in a special place on our YouTube channel. If you're a fan, let us know. If there's a subject you'd like to hear us cover, let us know. Right now, we kind of go with things that make us passionate and things that, we think we need to get out to you guys quickly and in a real way that you can digest. But we want that feedback. We want to know, what you think of it and what you'd like to see going forward. And if we make a mistake, please let us know, because we will fix that mistake, because we will die on the hill of accuracy. So thank you guys for listening to us a second time. And if this is your first time, hey, you got the right one the first time. So Cindy, thank you so much. And everyone, be safe.
Have a good day.